Hey YouTube. Okay, so this video is gonna be on more meds. We have respiratory, endocrine, and hematologic meds. So I just got done. In case you didn't see the other two videos that I posted for an NCLEX review, I just got done doing a 3-day NCLEX review with ATI. That was included in my tuition. So just got done doing that. So I'm using my notes in their book and going over what I have in my notes basically. And I added a little tiny bit to it. There's way more information in the book, but that I'm not going to get into because it would just be like stupid to sit here and talk too much. So you'll basically get like a couple points on each med, and then it'll be a refresher on the names of the meds and the category. Alright, so respiratory meds, you have your beta-2 adrenergics. Albuterol is going to be your rescue inhaler. After that, they're supposed to rinse their mouth out. There's also beta-2 adrenergics called formoterol and salmeterol. Those are inhalers, but they're long-acting. Okay, so there's a pill that's long-acting in the same class called terbutaline. And with these meds, tachycardia is expected. I'm pretty sure they just get that every time. Another respiratory med for, I guess asthma. Let me see. I mean, they dilate smooth muscle, so it could be COPD as well. This one is for long-term control of asthma or relief of bronchospasm. Okay, and then the beta-2 are bronchodilation. So, the beta-2s are pretty general. So with these meds, methylxanthines, they would avoid smoking because it decreases the effects. This is a long-term control med. So for endocrine meds, you have metformin. Metformin increases the sensitivity to insulin, but it can't be given with contrast dye. So that was something she went over on metformin. She didn't go real in depth on each PO med for diabetes. And then we have hypothyroid meds and hyperthyroid meds. For hypo, you would take levothyroxine. And it's like really early in the morning before breakfast. It's usually 6 a.m. Hyperthyroid, you would have, they would get methimazole, and obviously it inhibits thyroid. And then for adrenal replacement, they would get any of the steroids. There's dexamethasone. I just put that as a example. There's also hydrocortisone, fludrocortisone, prednisone. So you would use this in Addison's disease, inflammation, allergic reactions. Okay, so if they're on it for an infection and not long term, then they would have to, if they're gonna get off it, they would have to taper off it because they could have some adrenal suppression. So you have to give the body time to adjust and get back to normal and start secreting again, because the adrenal gland just isn't doing much when you're getting the what's it called, the steroids. Okay, so for insulins, just know your rapid, short, intermediate, long acting. Rapid is Lispro. It acts in 15 to 30 minutes. And then what else? Short acting. Let me say half hour to an hour. And then intermediate is 1 to 2 hours. So where one leaves off, the other one would start. But that's how I remember it. And then long acting is the Lantus, but it's called glargine insulin. And then to draw it up, some places she was saying like the NCLEX is like a national test, so it's not specific to your state. Like I've never ever seen insulin being mixed, but some hospitals and stuff they still mix insulin, so you need to know how to mix the short and the regular. And you just remember Nancy Bragan RN. So the MPH, you would do the air and the MPH, then the regular, flip the regular, draw up your dose, and then go back into the intermediate, draw up your dose. Nancy Bragan RN. That's how I remember it. So that's how everybody remembers it, probably. So for blood products, LPNs cannot do these meds. Now, for a blood transfusion, after it's hung and the nurse stayed with the patient and ran it slow for the first 15 minutes and they're confirming that the patient isn't having no reaction, they're fine, the LPN can monitor from there. That's what she was saying in the ATI review. Okay, so, but you can't delegate these meds out, and this includes ROGAM as well. They can't be delegated to anybody but the RN. So for packed red blood cells, it depends on the situation. If the patient has heart failure, they can't get it fast, but maybe for like a trauma victim or something like that where it's urgent, they would get it over 30 minutes to an hour. I don't know what the minimum time is for a blood transfusion, but the max is 4 hours. So if they're having a reaction, you gotta stop it right away, hang saline, tell the doctor, and then get your urine samples, blood samples, and send that along with the I don't know if it's the tubing and the bag of blood, but you send it all back to the lab, and then they look at the blood. 1 second, let me shut the door. So that's it for, and then you also have the platelets. You don't need to type and cross, and fresh version plasma. Those are your other blood products. And ROGAM is considered one too. Alright, so for more on hematologic meds, you would have your growth factors, filgrastim and pegfilgrastim for neutropenia related to cancer. So it stimulates white blood cells. I don't know how to say this one. Opralvecin stimulates platelets. Okay, so for iron, there's a bunch of stuff. Like in general, you can't have coffee and tea with it or within an hour after administration. It'll decrease the absorption and just make it pointless, basically. So they need to be educated on that. They would take it with vitamin C. That's good to do. And then with the liquid, you would use a straw. They can dilute it in juice, and they don't want to get it on their teeth, so they would rinse afterwards. If you're doing an IM, you would use the Z-Track method with a 3-inch needle and a 19-20 gauge, and you wouldn't massage it. So for the anticoagulants, you have heparin and warfarin. For heparin, you would monitor the PCT, and then if there is toxicity, you would grab the protamine sulfate, and heparin is given sub-Q, and you don't aspirate or massage. So for IV, you would monitor the PTT, I think every 4 hours. Okay, so for warfarin, you would monitor PT or INR. In the nursing home, I know they monitored it. Oh my gosh, my hair. They monitored both lab values. The antidote would be vitamin K. It's a once daily med, and it takes 3 days to start working. So if they're already on heparin, it's okay for the first 2 days, and then they would DC on the third. Because the Coumadin takes, which is warfarin, it takes 3 days.